Welcome back. This session is called Optimization of Atrial Pacing Site, Placement of the Aveir System at the Bachmann's Bundle location. And we're delighted to welcome our case presenter, Stephen Bailin from the University of Iowa Hospitals, Iowa. And we also welcome our fantastic panel for the session, Brett Atwater from Virginia and Ricky Green from San Diego. Over to you, Stephen, for the case.
A number of consulting disclosures. So I wanted to provide a little bit of history, and as a senior electrophysiologist, that's kind of my job now, is to give the well and back in my day talks. Most everybody else is much younger to remember. But back in the 90s, as you probably know, there was really only a surgical option for atrial fibrillation ablation, and therefore, primarily treatment was based on giving antiarrhythmics and antinodal agents, as well as a nodal ablation, and dousing patients with large doses of medications resulted in a fair number requiring pacing. And of course, AV node required pacing. But we knew that atrial fibrillation was associated with disparate conduction through the left and right atrium caused by fibrosis and loss of connection. And if you looked at patients with paroxysmal atrial fibrillation, the P-wave durations were longer, as well as abnormal signal averaging. And as a result, we sort of wanted to look at ways of improving atrial activation. And there were a couple different proposals. One was dual site atrial pacing, where the leads were placed in the RA and the CS. But in looking at things, I was interested in maybe a singular solution. And back in 1912, I think Dr. Bachmann described the the exterior sorts of fibers that sort of connect the left to right atrium. The origin of Bachmann's bundle kind of is near the crista terminalis at the junction of the SVC and the right atrium, so quite near the sinus node, and acted as a way to conduit activation into the left atrium from the right. So the idea was to pace in this area, and initially we had to define it. We did that by sort of acute studies looking at activation timing in different pacing positions, and other groups also evaluated this, and this was from their report, where basically you can see the activation is much more homogeneous and quicker with Bachmann's position than other places in the atrium, particularly the right atrial appendage. So we started placing leads at Bachmann's bundle, and we defined it primarily anatomically. The lead needed to be placed in the septal region, high in the septum. So in the LA view, it was pointing towards the septum, and in the RA view, it was pointing anterior. So superior, anterior, and septal was the target. Of course, the implications of the site was that we could demonstrate shortening of the PR interval, as well as shortening of the P wave duration. And we'll talk about sort of the morphologic characteristics. Subsequently, we sort of did a randomized trial to look at the outcome of patients who received Bachmann's pacing, who had a history of atrial fibrillation, and compared it to right atrial appendage pacing. Approximately 50% of those patients had AV nodal ablations. And what you can see is the data demonstrated that Bachmann's bundle pacing resulted in a shorter P wave duration compared to sinus or right atrial appendage pacing. And more importantly, if you look at the morphology of the P wave, what you'll see in the inferior leads is a shorter P wave duration, but the morphology is slightly different. You will appreciate a more rapid upstroke of the P wave. And that really defines whether you're in Bachmann's bundle or not. The result of that study was relatively dramatic. There was a significant difference between patients maintaining sinus rhythm who received Bachmann versus the right atrial appendage pacing. And subsequently, studies, in particular from Vermont, have sort of also suggested a decrease in um, atrial dysrhythmia. One other advantage that was demonstrated somewhat later as CRT therapy came out was that by accelerating electrical activation to the left atrium, you could accelerate mechanical contraction as you might expect. And therefore, when dealing with CRT patients, it was important, I think, to allow activation to occur. So I think there are some challenges, and certainly I'd be interested in hearing everybody else's thoughts about it. But I think in general, the delivery sheath is not optimized for use in the atrium. Additionally, coming from below, the anatomy may be challenging based on rotation or horizontal or vertical variance because the deformation of the curve occurs fairly distal. It's sometimes kind of difficult to make sure that you're actually deflecting in the right direction. And additionally, some patients don't have kind of a shelf between the SVC and the right atrial septum, and that sort of smooth um, access point to the Bachman's bundle may be challenging. So in general, this is what I recommend doing. Initially, I place the catheter delivery system into the SVC. That sort of defines the upper portion um, of the right atrium and also sort of where the SVC is sort of slanted or out of position. You might be able to detect that. Try to get a curve that moves towards the septum and the LAO view, and then pull the system down. If the patient has a shelf, you'll probably see a jump towards the septum. Otherwise, unfortunately, you do have to just kind of test positions to see if you have adequate sensing and pacing. Um, if you have to maintain curve, initially 2 or 3 turns on the catheter will at least anchor the system before you completely relax the curve. So again, how to define success anatomically, the Aveir is superior, anterior, and septal. So in RA view, you can see it in the anterior, and LAO, it's high and pointing to the septum. But most importantly is the P wave morphology. You should see it shorter, and you should see the upstroke, as we talked about, being much more rapid. So what I'm presenting today is kind of not the best case. But I think it's instructive in any case. I will show a more practical position. This was a patient who was referred as a 50-year-old with known symptomatic bradycardia complicated by paroxysmal atrial fibrillation. The patient underwent PFA with pulmonary vein isolation, but did have some triggering along the SVCRA septum, and PFA was applied into that place. Post-procedure, as you might expect, there was significant sinus node dysfunction. There was some recovery. However, because of her prior history, it was felt that she would benefit from pacing, and therefore we took her to the lab. This first shows the catheter moving from the, yeah, not seeing it work. Um, sorry. It should be moving towards the SVC. Hmm, interesting. Sorry. Oh, there it goes. So you can see it just move to the SVC. I have a little bit of curve on it to the anterior, and we also look at the lateral, as you can see here, that's pointing to the septum, and it's along the SVC-RA junction. So here we exposed it This would be where we would expect sort of typical position. Unfortunately, probably because of the PFA in that region, we were not able to have successful sensing and pacing. So the other area I sometimes use is sort of the atrial uh, anterior septal lip, um, because if you remember the illustration, Bachmann's rundle does rise slightly posterior to um, the right atrial appendage, and you can sometimes interact with Bachmann's at that level. However, typically the you won't see the morphology and the uh, P-wave duration may not be as short as sinus rhythm. So here I am in sort of an RIO sort of look. As you can see, I'm sort of at that anterior septal uh, position. But again, unfortunately, that was also not a ideal place. So then we came down a little bit more septal. As you can see, we're quite a bit lower, and we're against the septum there. We then checked our position, and it was adequate. The catheter was placed and removed. Again, we used testing then at the tether. And at the conclusion, this was removed. And as you can see, it's quite low relatively. That's the RAO view. I'm sorry, that's the this is the RAO view. So quite a bit lower. Nonetheless, if you look at the P wave, it's probably about sinus rhythm, which is I still think quite a bit better than around the appendage, where you see a quite large P-wave duration. The Vermont group has looked at various positions within the septum, and clearly the achievement of the morphology at Bachmann's bundle is important in the suppression of arrhythmias. This is from our case report. Again, you can see we're up against the transition at the septum. And this was the RAO view. Again, you can sort of appreciate it's quite a bit higher than the original. And this is what one would expect, ideally. You can see sinus rhythm P wave on the left, and Bachmann's bundle P wave on the right. Those are lead 2. And I think you can appreciate the narrowness of the Bachmann, as well as sort of the more rapid upstroke. So we have looked at how successful this is. And we had, I think in this submission, we'd had 17 patients. We were successful in getting Bachmann's about 76%. So there are some patients that do not seem to, with the current system, able to achieve a Bachmann's bundle site. So I think that the main takeaway from Bachmann's bundle is that pacing at Bachmann's bundle results in more symmetric and homogeneous atrial activation. It results in a shorter P wave duration and decreased atrial activation time.
Okay. Can you hear me? Okay, perfect. Brett, I think we lost connection with Stephen. So let me bring
I've
you in, Brett,
lost.
and ask. Oh, he's back.
I seem to have lost my last slides, but anyway, I was going to talk about future directions, and I think number one is how do we optimize sort of the sheath. Number two, and I would sort of ask the panel's input on this. I know that some of the implanters are using the right IJ, and as people are looking towards the left bundle area pacing, oh, there it is, left bundle area pacing, um, that that might be, I got it back. Uh, that might be a preferable way to do it, although I think the curve will be tighter, so I'm not sure about the torque transmission. But I think as we look towards sort of physiologic pacing, the importance of activating the ventricles as homogeneously as possible with early left atrial activation will be very important for mitral contraction. And I think the use of Aveir will be an important change in practice, and hopefully people will have more opportunity to do this as the catheters and technology mature. And with that, I would be open for questions.
Great presentation and a great case to show us. Ricky, let me ask you a quick question on just which patients do you consider as best for this? There's certain atrial arrhythmia patients that you think might benefit with this approach, or should it be the go-to for every patient that we go in for atrial implant?
Yeah, but I have to tell you, they're starting construction right outside our office right now, and I can barely hear anything. I could not have picked a worse time to sit there. Can you speak up so I can try and listen?
Oh, yeah, yeah. So, no, my question was, is there a specific patient profile that you think would benefit the most from this? And Brett, I hate Ricky's struggling with this. So, whether you want to take that question, maybe, should it be should it be the implant in every patient, or should we focus on a certain subset of patients for Bachmann's bundle pacing?
So I'd say
I
right now,
think
sorry, go ahead, Ulrika.
I was going to say, if I think I heard you right, Devi, on should we focus on a subset of patients? I am so sorry. This is,
Yeah.
I just can't hear anything.
All right, Brett, I'll let you take the question.
Okay. I think this is a tricky implant still. We're still learning how to do it. And I think that the procedural duration is probably a little longer than a traditional pacemaker still at this point. So we're still focusing the use of leadless Bachmann pacing on patients who have the most to benefit from it. So those patients, for example, who have an increased infection risk, certainly just a group that we would be looking at with sinus node dysfunction. But I think in the future, this may be our go-to for how to implant an atrial pacemaker as we get better at it and as the technologies evolve to make it an easier implant.
Are there, you have had quite a bit of experience with this implant, and you've done some work as well. Can you talk us through some of your data, Brett?
Yes, and we're planning to submit that to HRS this year, so it should be good to be able to talk to Steve there and try to get an understanding of how his experiences compare to ours. We've implanted now more than 10 Bachmann bundle atrial Aveir devices. Our success rate is similar, I'd say, to Steve's, probably around 70 to 80% success rate. In our cases, we're using a temporary decapolar catheter in the coronary sinus to help us understand when we do and do not have Bachmann bundle capture, sort of as a gold standard for left atrial synchronous pacing. We found that to be useful, particularly as we were getting started to understand what we're doing, because the pacing artifact can make it challenging to understand what the P wave duration is doing. And then we have used a lot of four-dimensional ice as well. We use New Vision for many of these cases in order to really lay out the anatomy and to understand what we're doing and how we can get better. So at sort of early phase of our learning curve, I think 4D ice has been really, really helpful. I noticed in Steve's example, he didn't have an ice catheter up. I was planning to ask him about that. And is that your routine sort of go-to workflow, or have you used ice as well? And have you found it to be useful?
Yeah, I think I haven't been using ice, but I think it probably is useful again in the patients that don't seem to have that sort of shelf where there's kind of a drop. I think it can be challenging because in those patients can be kind of a smooth transition. So I think ice would probably be quite helpful. I found having done the lead implantation from above, it's relatively straightforward compared to, as you say, the Aveir, which has its own challenges. I would say that having ice is a very reasonable approach, and probably does uh, cut back a little bit on the hunt and peck, particularly as you're trying to define that sort of superior position, the transition between um, the SVC and the RA. So I would be interested in seeing what you look like.
And I come in with a question. I hear a little bit better right now. I have a window of opportunity. What kind of pacing thresholds have you been getting on the 17 patients that you presented in your slides?
Yes.
And with that, what kind of battery projection?
Yeah, so there are two issues, as you know, with the Aveir battery. Number one is the threshold, and it appears that compared to the other sites, it's very comparable. It's similar to what we saw with lead pacing. I would say the majority are under 2, probably under 1.5. Sensing tends to be pretty good. And it appears to be stable over the 6 months. So I think in our submission we have some of that chronic data, but that's been our experience.
Brett, is there a threshold for intra-atrial conduction delay intra-atrial conduction delay that predicts or say greatest benefit from Bachmann's bundle pacing?
There is. If you have a baseline intra-atrial conduction delay defined as a P-wave duration over 120 milliseconds, particularly if you have a bimodal or biphasic P-wave where you have a negative component for the terminal portion of the P-wave and leads 2, 3 in AVF. Those are patients who have evidence of Bachmann block and left atrial conduction primarily through the coronary sinus. These are patients who have a particularly high risk of atrial fibrillation with pacing from the appendage and have the most to gain from trying to resynchronize the atrium and produce a more normal conduction pathway across Bachmann bundle. They're also some of the more challenging cases to get successful Bachmann capture on. Those have been the two that we have had difficulty with, were patients who had complete Bachmann block on their 12 lead EKG going into the case. We had a case report, the first case report of leadless Bachmann pacing. That patient on her 12 lead EKG, you can see, has complete Bachmann block at baseline, and we were able to successfully get Bachmann capture. So it's not a guarantee that you can't get it done, but it does make it more challenging, certainly.
Yes, we were having discussions on PFA all morning, and PFA within the SVC in these proximal AF patients. And so after your case, now I want to ask the panel what their thought is, because there is a subset of operators that truly believe the SVC does have 10% of triggers, and routinely, because of the ease of doing or safety of doing SVC isolation, now routinely do it. So is that something we should steer away from?
I would say
Right,
clinically.
you've done some work with Aveir and mapping, right? Yeah.
Yeah, I haven't had in a human. I have not had sinus node dysfunction with an Aveir ablation in an SVC. In animal work that I've done, I have had complete destruction of the sinus node with ablation in the SVC using both pulse field and RF off of the Aveir catheter. So I know that it's possible. It's designed to deliver a transmural lesion, and it does that effectively. So I'd say be particularly cautious if you're anywhere but the septum and the SVC.
Yeah, I think that's absolutely true. With the Farapulse, typically it's done with the basket formation. So to some extent, you can kind of limit your posterior lateral exposure, but I guess I think if you're going to do it, that this will be one of the potential consequences for it.
I don't
I'm
do
gonna just
ablation,
ask
so I
a
can't
general
render an
question.
opinion.
It's okay. So, Ricky, I'm going to ask you the final question of, what do you think the next generation of our platform or the leadless platform should have to make this kind of the default? I'm kind of putting you on the spot and being naughty there, but what is going to make this easy for everyone?
Yeah, so the next generation of your platforms, I'm just gonna first of all gonna say, I haven't done a transvenous dual chamber pacemaker in 6 months, I think. So, just the whole idea about getting away from leads to leadless pacing, I think it's absolutely fantastic. And I think this is interesting. The Bachmann bundle, I like the concept. I'm a little bit worried about taking what I think is a very straightforward procedure and making it potentially a little bit more difficult. So I'm hoping that we can continue to strive for making this leadless implantations as straightforward and easy as possible with good battery life.
Yeah, I guess on that note, I will have to close the session. My thanks to Stephen for a great case and great discussion, and Brett and Ricky
Thank-
for their excellent insights. Next, the focus is left bundle branch pacing, coming right up.
Thank you.